Begin here. All right. Well, good afternoon, everybody. I'm so glad that you showed up, and thanks for those of you who showed up early. My name is Garrett Schmidt, and I am the managing editor for BBC Exhibit Hall. And I would like to welcome you to today's live webinar, which is hosted by Edifecs, and it's called Maximizing Financial Performance Under Value-Based Care, which I'm really excited personally to hear about this. I got a sneak preview, but when we did our practice run, and so I think you're really going to enjoy the presentation today. And a few items of note, everyone has joined today in listen-only mode. This is a traditional webinar format, so you don't need to worry about muting your phone or turning off your camera. We can't see you, so don't worry, but we're glad that you're here and we want to hear from you. We are going to have a Q&A session toward the end, so please submit a question at any time. You don't have to wait until the Q&A in order to do so. Everyone has a little control module as an attendee, and there's a place for questions on there, which is different than the chat. So if you have a question and you'd like to ask it, and we'd love to answer it, go ahead and submit it there at any time, and we'll get to as many as we can during the allotted time. We've got a lot of information to cover. And then finally, the session is being recorded today. So afterwards, I'm going to send out, or one of us will send out a link to the recording where you can also download the slides and interact with the team and reach out to them there. So that will come after we conclude the presentation today. So at this time, I'm going to pass it over to Mr. Ted Sawyer, and he is going to introduce himself and our speakers today. And then I'll see you again during Q&A.
All right. Thanks a lot, Garrett. Well, healthcare it's really at a tipping point as it transitions to value-based care across government-sponsored programs. In this new environment, the fee-for-service mindsets and strategies won't work. Providers who attempt to address the new affiliated operational and financial challenges with fee-for-service methodologies are going to face some internal friction among care teams and revenue leakage. So in this session, we will learn about the 3 layers to adaptive VBC transformation. 1, incorporating data-infused goals in the contract design. 2, enhancing visibility into all VBC programs through real-time financial performance management. And 3, shifting risk adjustment upstream prospectively and with automation. With an end-to-end ecosystem that organizes stakeholders across all alternative payment models, Edifecs' technology lays the foundation for uniting financial and clinical worlds. With a mission to better understand patient needs, stratify them by risk, engage effectively, and track outcomes over time. So speaking today, we have Betty Stump. Betty serves as an Edifecs solution consultant focused on supporting customers seeking to incorporate technology solutions to solve the complexity of risk adjustment capture and reporting. She holds numerous credentials in health information, coding, clinical documentation integrity, and has a master's degree in healthcare administration. Mike Patwell is Edifecs' principal business advisor for value-based care. He currently serves on the board of directors at WEDI and is the chairperson for the WEDI Payment Models Work Group. Mike also participates on value-based payment advisory boards at CAQH and the Da Vinci Project, focused on driving standards adoption to move our industry toward value-based care. With that, I will hand it over to Mike.
Thank you, Ted. So welcome, everybody. Thank you for joining us today. To set the stage for today's session, most of us have probably seen recently the announcement by CMS that they are targeting and looking towards not only CMS and their Medicare populations, but also to the state Medicaid directors to also either up their value-based payment initiatives or get started. So there's a 100% goal by 2030, which is pretty aggressive. I'll start just on the left-hand side here. So there's a pretty a good program called Medicare Shared Savings Program, otherwise known as MSSP. So that's still in play, and it's been very valuable, moving the needle on the Medicare Advantage traditional. Pioneer ACOs and the next generation ACOs really laid a great foundation for direct contracting models, but recently CMS and CMMI reintroduced what we're calling the ACO REACH model, both the professional and global tracks. So Medicare is really pushing hard, and you'll see some statistics in a few slides. On the right-hand side, you can see that there are many state Medicaid agencies that have already started, in some cases over a decade ago or even more. I won't list them all out, but I will talk to a couple where there's a performing provider system, a PPS. This is New York State. They had a DSRIP, or through a 1115 waiver to CMS. They got permission and got funding of about $6.8 billion back in 2014 in order to transform the Medicaid in the state of New York. You may know or may not know, the state Medicaid in New York is a very large population. That program terminated in 2020, and then they reapplied for an additional 1115 waiver to CMS. And they are looking to address some of these shortcomings that were, in a postmortem, looking at how successful they were with their first delivery system reform incentive program. They are now calling PPSs HEROES, and that stands for Health Equity Regional Organizations. One of the things they found was that there was some overlaps with the PPSs. So this regional organization term is to make sure there's no overlap. So in distinct areas within the state of New York, there's going to be a health equity regional organization responsible for distributing the funds, which I believe is around, it's over $13 billion. And they're trying to really radically transform and get to that 100%. In the earlier one, I believe they got around 75, 80%. I could be off by a few digits there, but their goal was to get to 80 to 90. That was what they stated to CMS in order to get the district funds the first time. And then the second bullet you could see is coordinated care organizations. And really what I'm pointing out here is that each state is unique. That's what makes us great, right? So each state is going to call things and terminology different, but coordinated care organizations, I think, have been around almost the longest, right? So this is the state of Oregon. They have a very unique, and I believe they're on their third iteration of what they call their value-based payment program. And it is in trying to do all the same things I listed that New York and other states. And I'll list, there's so many states, I just want to just target in on 3 here. And then the state of Massachusetts, they long have been trying to transform healthcare in that state, right? I think that's where we all grew our Accountable Care Act information and how we moving to everybody having health insurance. I think that state has been the leader in that point, and they have a Medicaid ACO. And what they're trying to do there is trying to align the providers and the payers and the community organizations together under multiple tracks that can be selected by these Medicaid ACOs. And from early reports that I've seen and have been on webinars, have some colleagues at WEDI and CAQH, it's going really well. So these are 3 state Medicaids, and CMS submitted a letter to all state Medicaid directors to aggressively move away from fee-for-service and move towards a value-based payment. So you can see on the bottom there, CMS wants to support similar growth and alignment, really, with payers and providers that are serving commercial insured populations. While they don't have that reach, they are hoping that multiple payers and providers that do also serve Medicare and Medicaid populations would also, start to align with some of the progress that the government-sponsored plans have. And you'll see some statistics later why that's very important and why in this webinar we're going to focus on the government, as Ted introduced. We feel that's where they're putting, right? That's the tipping point. There's a lot of complexity coming in, so you can move to the next slide. Really just want to address so the goal for today's webinar, right, is to focus on provider organizations that are providing value-based care today. Doesn't mean if you're not and you're looking to get into it, this will not be helpful. But what we set the context for what we wanted to deliver and what we wanted to discuss, we figured we would ask and then ask these 3 questions. So are you in a value-based care model today? Do you believe you're doing well? Probably, definitely on the clinical side. I mean, I believe all doctors all providers, all hospital systems, health systems are out to make everybody well. But are you looking to enhance your position in the future? Are you seeing what CMS and state Medicaids and possibly some commercial payers are now asking you to do? So are you looking to enhance your position? The second question would be, are you prepared for these newer models, right? So a lot of risk, downside risk, episodes of care, very complex to implement, partial, full capitation. Again, another very complex and risky endeavor for a health system or a provider system or an individual provider to take on full capitation, literally taking the full risk that usually the payers or CMS or the state Medicaid takes on. And then last would be, we need to go full cycle, right? So you can't just look at the value-based care contracts and the terms and the financial and the clinical measures. You really need to, concern yourself, are you leaving revenue, behind, right? Or do you need to advance your clinical coding and your automation and maybe some technology to address, risk-adjusted factor scores to accurately predict costs, because it's going to be important year over year that you have that right. So really, our goal is to provide insights into how you could be successful within all value-based care contracts and what's required. What is what technology, what data foundation, what operational infrastructure, including automation and technology is required. So let's start by level setting, right? So there are a number of various contract models today. You can go to the next slide, Ted. And what I'm referencing here, and it is adapted, but the Healthcare Payment Learning and Action Network, HCP LAN, developed after the Accountable Care Act assigned them to be watching value-based payment contracts across the nation. They put out this alternate payment model framework, and what they looked to do was to categorize the various types and complexities of value-based payment programs. So starting on the left, category 1, that's the way it's always been, right? So you address a member or a beneficiary's needs in the point of service, and you submit a claim, and that's how it's been for a long, long time, right? So fee for service with no link to quality, no link to value. What we're trying to move to, and a lot of the MSSP, the early endeavors from Medicare and other ACOs, even on the commercial side, was to let's address. So in the beginning, there was patient-centered medical home, right? So we're looking to the payers that are taking the risk on, are looking to help providers, help them build out operations and technology and give them additional payments to possibly set up, employees within that organization to address some of these quality things. So we started with, a care coordination payment. So a PMPM or some type of a dollar amount each month per beneficiary from that payer or from CMS or from a state that you would actually get additional money above and beyond. So that care coordination fee really had no risk, and it was just some extra dollars in order to set out that, excellence in serving a population different from a fee for service. Then we moved in, we heard from macro MIPS and the pay for reporting, the PQRS submissions. Pay for reporting was, all right, so you're going to get some additional money if you submit these quality measures for our beneficiaries, for our members in the field. We want to know how it's going beyond just submitting claims and encounters. And then also there was a piece where it was even brought a little bit higher, and that was pay for performance. So incentivizing the providers to improve those outcomes. That came with a little risk, and it was just that you needed to really address some technology and bring some operations in to gain that additional dollars for a pay for performance. Moving to category 3, that's where, shared savings. You're going to start to see that, provider risk is going to grow. And in some of the cases, like a shared savings program, there was what was called a upside risk only. And that's where we're looking at in this first box, is it's only upside risk. There was additional dollars in order to do the quality things like category 2. But then you move into the middle box where it's shared risk. So this is what they call upside and downside risk. So there's more dollars to be attained while providing quality, but then there was some skin in the game, right? So if you were not maximizing the quality for your beneficiaries or your members, your patients, there could have been a penalty. There could have been a withhold that was not going to be given to you. So shared risk in the middle side had a little bit, you could see by the red dollar, that there's some downside risk there. And then episodes of care, a real complex model where still trying to figure that out. We believe here at Edifecs, we have a solution to go down to the member, risk adjust that member that's in an episode of care, but it's still far off from being perfect in episodes of care. So there's a lot of upside. If you're a very efficient, for example, if you do total joint replacement and you can, look at some of the metrics and some of the procedures that are wasteful and eliminate them, there's a lot of dollars. There's you can see there's $3 green dollars, but then there's also a risk where, no matter what is in your control, maybe you are that orthopedic doing the surgeries, but then the downside, physical therapy starts to mess up, you're responsible. So the episode of care is a little bit more complex, a little more risky. And then we move to category 4, right? So many organizations start here. You're just in a full capitated risk piece and you manage it, but there's also a conditions-based management, condition-based payment side, and there's really no downside risk. It's just that the provider or CMS or the state is giving you extra dollars in order to manage a specific disease state or disease condition state. And then we move into partial and full capitation. You can see that partial, there's still risk and there's still reward. But in full capitation, this is where everybody's trying to move. I think post-pandemic, we noticed that, a lot of providers, a lot of health systems, hospitals, they kind of didn't do well, and they're now looking. We hear our payer clients coming to us looking to implement and have a full capitation program where in previous they didn't. But again, you're going to look at the risk scale on the bottom that, when you get to these, you really need to have a robust data governance, you need a robust technology, you need robust infrastructure and education out to everybody involved. All stakeholders involved need to be on the same page. You can go to the next slide, Ted. So, how do you, right? So how can we all succeed in value-based care contracts? It comes down to managing your populations, right? So, you got to manage your population's health. You need to incent the members or the beneficiaries to do the right thing themselves, right? That's part of the equation that is always missed from, discussing value-based contracts. You're always looking at the payer, you're looking at the provider, and you're not, looking at, well, what is that patient? How's that patient, engaging his own health or her own health? So I think on the left-hand side, population health, the nation has really moved. The whole EMR push and funding really brought a lot of automation, a lot of technology in order to address population health. You have patient engagement tools, you have patient stratification tools, chronic disease management, both from the payer historically and now down to the level of information sharing to the providers and being able to manage chronic disease, even when that patient or beneficiary is seeking services additionally outside of your purview. Clinical integration, right, with the EMRs, closing gaps. When you start to look at in a government-sponsored program, there's a whole risk adjustment factor and score that drives a lot of your future payments. So you really need to have that education. You need to have everybody on the same page as far as clinically coding, and Betty will address that in a little while. And then the quality measures, right? This is something that we haven't been able to standardize. Maybe in some programs we have, maybe HEDIS, NCQA, and they've really, NQF, have done a great job of trying to quantify that, but it's still different, right? So you may have a program that's looking at some hybrid measures, some facility measures, not even clinical, educational, staffing, education, staffing, resources. There's so many different quality measures, it's very difficult, but I believe the population health management solutions are doing a great job. The EMR systems that are addressing this are doing a great job. Where we see a lot of struggle and a lot of challenges are on the right-hand side. So when you look at the financial risk, right? So you're pairing risk adjustment with payment and regulatory incentives, and the risk coding really becomes paramount. As we'll find out soon from Betty, there's even ongoing changes that are now starting to be implemented this year and over the next 2 years. So there's some disruption in that. There's also this new health equity bringing more complexity. As I mentioned earlier, the ACO REACH model has been trying to now address social disparities and access to care for everyone. So that adds another complexity. I did have the honor of speaking last week with the Medicare director, Liz Fowler, and through questions, through some discovery, we're going to be seeing some reporting out, early reporting on success or some challenges with the ACO REACH program. So look for that, this month. I believe she promised last week to me. And then provider transparency, and not just provider transparency, but all stakeholder transparency. So in a provider organization, every provider has to be on the same page. Every provider needs to be provided the same information, the same infrastructure, the same automation, the same technology to help them do their job on the left-hand side and not have to worry about the right-hand side. So you can move on, Ted, please. So how do we do this? The million-dollar question, how do we, here at Edifecs, we like to start by assessing, what we call the provider maturity matrix. And you can probably notice on the left-hand side, you can see those HCP land model categories. So category 1, and the example there is fee for service, right? No link to any quality or value. And if you look at the right, in green, right, which is you just need some basic technologies, basic operations, data excellence, care coordination, risk analytics, right? So that's what you've done. Basically, you submitted a claim and you got paid, and you use your revenue cycle management tools to say, was I fairly compensated, or should I be talking to other payers and contracts? But there was really a low bar as far as technology and operations needed. When you move to a category 2 model, right? So looking at care coordination payments, pay for reporting and performance, you really need an intermediate step. There's additional staff, there's additional technology that is required and operations in order to be successful in a category 2 program. On the data excellence side, the care coordination side, risk analytics, I believe you're in the same. So we're trying to be honest here that, with the same staff, with the same data that you're working with, and care coordination procedures, and with risk analytics, you're pretty safe as far as, staying with some of your basic, documentation capabilities. Now let's move to category 3, right? So shared savings, shared risk, and episodes of care. This is where you really need advanced technology, advanced operations, and really need to step up to at least an intermediate side on the data excellence, data collection, data use, analytics, and care coordination capabilities. You really need to build those circles of trust, circles of care teams, and share that information across the board. So there's a mix of advanced and intermediate capabilities needed to be successful in a category 3 model. On the category 4 side, you can see blue across, right? So advanced technologies need for you to be successful, whether it's the payer, whether it's the provider, engaging the members and beneficiaries in a full capitation. You need across the board advanced technology operations, data excellence, care coordination, risk analytics. So we also, when we speak to our provider organization clients, we kind of put things in 3s, right? It's always good. You can go to the next slide, Ted. So we have the tipping point, right? Ted has mentioned that there's, a large push for government programs. Government programs are pushing the envelope on value-based contracting. And if you just look just at the growth of the Medicare Advantage population, you can see that, over the past decade, we've added 28 million lives. So we're looking at a very large population and growing, moving away from traditional Medicare. Plus, you look at traditional Medicare itself and then drill into the ACO population. I believe we're up to about 13 million, at least calculated from last year. And I think we're going to see it even larger. And as we see ACO REACH start to move out and get more popular, it's probably going to be even more. So just putting those two together, we're in a very large population. So this is going to affect hospitals. This is going to affect providers everywhere. And then add to that the state Medicaid value-based care. contracts and programs, all through 1115 waivers. The delivery system performance incentive programs are really driving another even larger population. Finally, adding the exchange, right? So I believe the numbers this year are way higher. We're still waiting for full tabulation since certain state-based exchanges continue to bring on enrollment. We also know the emergency has ended, so there's going to be some fluctuation. So we are waiting. So we just looked at 2022, and even there was an 8% year-over-year growth in the exchange. So if you look at this and you finalize, you're looking at a very large growth pattern that we need to address, right? So just over the last 8+ years, we've added 50 million lives to this cohort or this population run by government-sponsored plans. So that's what's large. So we get to the 3 initiatives that the highest performing providers that we work with each and every day, providing them solutions. We feel number 1 is important because if you can see it in the top right-hand corner, we have fingerprints. Back in the day, we used to use belly buttons to talk about populations, but we'll go with fingerprints here. But you can see we're addressing everyone here. So in addressing value-based care contract administration excellence, you need to address your full population, not just a stratification or a cohort or highly comorbidity beneficiaries. You need to address your whole population. You need to orchestrate and automate all your operations and your analytic components across your various programs. And in many cases, that's programs with CMS, with Medicaid, with commercial payers. That needs to be orchestrated. And you also need to use technology, whether that's artificial intelligence, machine learning, deep learning, natural language processing. The docs are doing what they're doing and they need the help, and technology is what's going to do that. So what we see our highest performing providers are doing are orchestrating and automating using technology, and really through that have a very comprehensive longitudinal record of their patients and their beneficiaries. And they're able to distribute that at the point of care, at the point of the services are being addressed, whether it's properly coding, properly looking at last year, making sure this year is forward. And in order to do that, we've seen with our payer clients, they're pushing hard to make sure that they're educating some of the lesser performing providers as far as when you're looking at coding. And they try to just bring that education side to it to get to them to increase their specificity of that coding. And we'll hear more about that when Betty gets to talk. But you can see that this transparency, this data collection, the highest performing folks are using that high level of technology and operations. So that's 1. Number 2 is it needs to be real time. It needs to be at the right time, at the point of care, at the point of service, in order to collect the right information. So number 1, you need to provide that visibility, right? So you need to know what were the outcomes, what outcomes are you searching for, what is the performance today, what are those interactions, and are you in some cases needing to reach and refer out to community-based organizations, right? So you need that real-time performance management. You need to be able to look beyond your reach as far as going out to organizations to help your member, your patient, your beneficiary out after he leaves or she leaves your office. And then you also need to be able to see with real-time technology where you need to course correct, right? So with this technology, you'll be able to look not only at clinical outcomes, clinical disease states, but also financial quality and risk, right? So anything and all that is part of a term within a contract, you need to be accurately monitoring and addressing those gaps moving forward. So with that, I'm going to pass the ball to my colleague, Betty, and Betty's going to go into the third initiative.
Thanks so much, Mike. So I'm going to talk about risk adjustment in value-based care because, quite honestly, understanding the burden of illness of the population is the backbone of value-based care. When we think about risk adjustment efficiency, it's traditionally happened at the payer site. The providers have submitted their claims, but they really haven't had a lot of ownership in it. Obviously, with value-based care, that impetus and ownership of risk adjustment data is shifting to the actual provider of services. And when we think about risk adjustment data, that information comes from a variety of sources. We start with our administrative data, so our billed information, our patient demographics, even some of our ancillary information such as prescriptions. This allows us to capture information about previously reported diagnoses, and this is largely what our payers have operated off of. But as we move forward, we're now looking at clinical documentation, and this is really the basis of where our codes come from. It has to be in the clinical record. It has to be appropriately supported in order for the condition or code to be captured. So when we think about risk adjustment deficiency, we want to look at administrative data, but we also want to look at that clinical data. We want to be looking at the progress notes, the encounter notes. We want to know what's in the patient's history, what's in the patient's problem list. And we need to pull that information together from all providers who render care to our patients that are enrolled in a value-based program. Now, together, that administrative and clinical data can be used to drive pre-encounter point of care review. This is an opportunity for qualified clinical reviewers to actually look at that information and tee up those conditions to our providers at the time of care. This allows for some of those remote conditions that may not require active ongoing management to be brought to the forefront. So things like our amputation statuses or ostomies, or even our patients with chronic conditions that are well controlled and a compliant patient that sometimes get lost from view. By using a pre-encounter review process and providing the clinician those diagnoses in advance of the patient's visit, we have a much higher opportunity to capture those chronic conditions that impact the member's severity of illness, and again, that use of healthcare resources. Lastly, as part of our process, we also want to be looking at a post-encounter coding review. Now, as an auditor, I can tell you that very often what I see is beautifully documented conditions in an encounter note, but those diagnoses never make it onto a claim form. Alternatively, I may see diagnoses that have been selected by the clinician that I can't quite find in that documentation. We don't expect our clinicians to be the best coders in the world. We have an entire profession of certified coders. But by allowing the opportunity for those specialists to review the documentation and the selected billing for the encounter, we can ensure that the diagnoses that are associated with that claim are going to be accurate and correct, are appropriately supported in the documentation, and that ensures that we've got the right information heading downstream from our encounter and our providers' services. So when we think about using NLP when it comes to suspecting, we're really looking at the overlap between the traditional process, which is usually claims data, as well as NLP used for chart analytics. And that's actually looking at, in most cases, a 3-year longitudinal record of the patient using that NLP technology to ensure that we're identifying all of those risk adjustable diagnoses that have been captured in the clinical record. By mapping the NLP derived diagnoses against the claim diagnoses, we're able to actually pull together the most comprehensive picture of a patient's risk adjustable conditions to ensure that we're fully capturing those conditions and reporting them as appropriate through claim submission or other avenues. Really, Edifecs' ability to tie together that NLP chart analytics as well as analytics of the claims detail gives us the most robust view of the patient's burden of illness. So we are aware that there is a major change coming to the CMS risk adjustment model. And if you aren't aware of this, you probably should be. With the final notice issued in April of this year, CMS has set the risk adjustment world on fire. They have proposed and finalized a transfer to version 28 of the risk adjustment model. Now, this is a wholesale shift of the model that's in use. We have over 2,000 diagnosis codes that are being removed from mapping to payment value, and an additional 200 diagnoses that are being added to the payment model with a payment coefficient. Most significantly, however, we have a great expansion of the number of HCCs themselves. So version 24 contains 86 HCCs. Version 28 will now contain 115 HCCs. So as I said, this is a pretty wholesale change to the model. Now, CMS did give us a little bit of grace, and they've given us a 3-year window to incorporate these new changes. Now, when we talk about these changes, these apply to payment year 2024. However, payment year 2024 is derived from information generated in treatment year 2023. So these changes are upon us right here and now. So over the course of the next 3 years, there will be a blended model as CMS shifts from version 24 to version 28. And on the slide, you can see that kind of transition period. And by year 3, we will be fully introduced or fully oriented to version 28. So really, when it comes to being successful with version 28, ensuring that we have comprehensive, clinically accurate and compliant coding is going to be the linchpin for success. So why did CMS make these changes? Well, they had very good justification for it. The first reason for removing a significant number of diagnosis codes was the understanding that that condition was unsuccessful or unable to accurately predict costs. So this has removed a number of the codes from the HCC model. They also removed codes in which they felt the coefficients were too small or were thought to be insignificant. So some of our more obscure conditions have been removed from it because those diagnoses really were not indicative of need for healthcare resources. They also removed conditions that were uncommon. So definitely ones that did not have codes that were conditions that were appropriately seen in a large portion of the population. And lastly, they removed conditions with well-specified diagnostic coding criteria. So when we think about some of the diagnoses that were included in the version 24 model, there was definitely a lot of conditions that had, kind of broad capture, but little or no impact to actually patient care. And the best example I can give of that is atherosclerosis of the aorta. This is a very, very common condition, was captured routinely, but by and large, the treatment for atherosclerosis of the aorta is simply watchful waiting. The patient would have, annual ultrasounds to gauge the progression, if there is any progression. But if the patient's being treated appropriately with statin medications, it may be that that atherosclerosis never advances, and the patient actually never needs medical intervention or care beyond that watchful observation. CMS really wants to bring the HCC model into the care that's appropriate for the members today, focusing on those conditions that truly predict costs associated with the care for those conditions. So when we think about what we can do today with this new announcement, if we're a provider, we definitely want to be focusing on identifying those conditions that have risk adjustable value. We really do understand that it's difficult to be successful in that endeavor without using technology. And this really comes in the form of AI and more specifically NLP. We find that using NLP allows for more effective and efficient identification of conditions that have risk adjustment weight to them that are predictors of healthcare need. By allowing the use of NLP, we can get a patient profile to the clinician at the time of care. That's going to help prompt the clinician to ensure that those chronic problems are being addressed, that the clinician is aware of what's happening with them, and that the patient is adherent to an appropriate plan of care. We definitely want to ensure that our providers are receiving education and training on risk adjustment. And this is really as much generalized education as specific education. We want to make sure that our providers are enabled to be successful in a risk adjustment world, and that comes with education and helping them to understand why this matters. And we always want to drive for improved clinical documentation. At the end of the day, it is that clinical source record that drives our coding. And the more precise, accurate, and complete the clinical documentation we have, the better specificity of coding we have. On the payer side, again, we have the ability to use technology in the form of NLP to do retrospective reviews. And this is going to be crucial as we get into payment year 2024, where we want to ensure that the information that's being submitted to CMS is accurate, is correct, and is appropriately supported in the clinical record. So on the payer side, using NLP is just as important to identify that in a most effective, timely manner so that we're really able to identify those appropriate conditions. This allows for an increase in production for chart reviews and claims validation, and just as important, allows for the deletion of codes that are inappropriate and should not be submitted to CMS for HCC purposes. We want to ensure that the codes that are submitted through and paid on are accurate and correct, and that includes removing those diagnosis codes that are incorrect. We want to reassess those interventions that may have been used in the past. In particular, CMS has been very vocal about the use of in-home assessments. So any organization using in-home assessments as a component of their risk adjustment program really wants to ensure that those in-home assessments are accomplishing the most appropriate purpose, which is ensuring that the patient is receiving the appropriate care. CMS was very critical of in-home assessments that are done strictly for the idea of farming HCCs. Their position is that a patient with a chronic condition should be receiving medical attention and an appropriate plan of care for that condition, and it shouldn't be something that's simply picked up in a one-time home assessment. And we want to make sure that we're working with our provider partners to ensure that they're focusing on the member's health. So as we look at value-based contracting and the shift to accountable care organizations, we're really seeing a much greater synergy between our providers and our payers. And that's going to be instrumental in success when it comes to value-based care. Our goal should always be the most appropriate care for the patient to ensure that we really are getting value for those healthcare resources that are applied. So with this, I'm going to turn it back to Mike to kind of bring all of our pieces together.
Great, thank you, Betty. Excellent job. Always learning something when Betty speaks. So just to wrap up, right? So those three high-performing initiatives would be to, take what you're doing in your current state, get that informed contract development, make sure that you're addressing some of the additional data elements that are needed in some of these more complex programs. Make sure you're doing what-if modeling and design, setting performance expectations, and using data within the workflow at the point of care, at the point of service. You also need that real-time performance management, right? So being able to orchestrate, being able to course correct, and also manage the financial risk. As I mentioned twice before, and I'll mention it again, docs and hospitals, they're all out there to do the right thing on the clinical side. In many cases, when we're speaking to our provider organizations that are in ACO contracts, they'll knock it out of the park with the clinical measures, with the terms in the contract that have to do with what they can control. What they can't control is the financial side. And what they need is that transparency, and they need it quick, they need it real time, and they need it way before the contract term, whether it's a quarter, a period, a year, is over, so that they can affect that change. And then you need to be prospective, right? With the new changes from V24 to 28, there's a hybrid measure change, but it's already upon us. So this year is going to be affecting the money and the revenue that'll be coming in to treat the same patients you're treating today, tomorrow. So you need to use technology, you need to identify and code correctly, and you need to identify and pull this upstream, make sure that you're resolving some of these undercoding, overcoding before you're submitting encounters to CMS, state Medicaids, and ACA, right? So the future state, we're going to look to have greater revenue integrity. We're going to enhance that visibility and control our value-based contracts, not having them control us. We're going to look at the alternate payment model and look at what we can scale, what risk we could take on, and then confidently move into and accelerate to any downside risk, which will be a benefit for all stakeholders, payers, providers, and the members and beneficiaries we serve. So here at Edifecs, we're proud of each and every one of our client partners, providers, health systems, payers. We're proud of the depth of our client base, and we're looking to use technology. We're using to help our client partners use technology to improve their RAF scores and make sure that the suspected conditions are going to be properly tracked. With the new changes coming on, we're looking to be that partner to help. We continuously work with industry organizations you can see across the bottom, like CAQH, the Council for Affordable Quality Healthcare, HL7, doing great things as far as moving us to standardizing and setting standards to begin with. Da Vinci, WEDI, the Work Group for Electronic Data Interchange, it's all important. The technology, the data footprint, how you can transfer data in near real time or real time to the point of service is what's going to make everything work in the future. So I'll turn it to you, Garrett.
All right, guys. Wow, well, there's a lot here, and obviously there's a lot of questions that I know are floating around. So if you have a question that you want to ask, go ahead and ask it at this time, and you use your attendee module in order to do that. There's a question section that's different than the chat. So go ahead and put it in there now. We're going to get to as many of these as we can. So in no particular order, I'm going to go ahead and start with this one. How does moving risk adjustment upstream put me in a more advantageous position with my payer partner?
Well, absolutely. The payers are looking for correct diagnoses on the claim. So by having the physicians be more invested in that process at the time of care, with that pre-visit review process, allowing the provider to be aware of the appropriate diagnoses that need to be reevaluated, documented, and coded, as well as the post-encounter review, ensuring that the diagnosis codes that are on the claim form are correct and are appropriately supported in the record. That reduces the burden on the payer for those exhaustive retrospective reviews. The better we can do the work up front, more correctly, more comprehensively, the better we have in terms of the information flow, and the more it reduces the back-end rework burden.
Yeah, great. Yeah, very good. Okay, next question here is, will prospective risk adjustment eliminate the need for retrospective reviews and chart requests?
Unfortunately, no, but it is our absolute belief that the better we can do on the front end with that coding and billing, the less we'll need to have those retrospective reviews. once the payers are more confident that the information that they're receiving about risk adjustable diagnoses is complete and correct initially, that will reduce the need for the payer to do those retrospective reviews. Unfortunately, they're never going to go away, but we would reasonably expect that they should decrease in the extent and volume required. Again, as I said before, the better we can do on the front end, the less work we have to do on the back end to kind of pick it up and clean it up.
Yeah, great question and great answer. Okay, next question here is what should provider organizations be doing in adapting to value-based care outside of technology investment?
Yeah, I think we went over it briefly, but there's a lot of education to all providers, right? So we'll find in certain organizations that we do our assessment, our maturity matrix assessment, where 90% of the providers are, working towards the terms of the contracts and effectively, but then there's that small percentage that are not, and that actually can affect, payments. Whether it's payments that were in a withhold and claw, or payments that were made and had to be, clawed back by the payer organization. So the education and making sure that all stakeholders are there. The technology is the enabler, but if everybody's not utilizing it, if everybody's not, on the same page, that's where the problems happen.
Yeah, I would definitely agree with that. And I think adding in that, having an open flow of information and transparency from the top of the organization down. Very often we find that there are, providers who really don't understand it, have never been given information on the value-based contract and the impact on them personally. So again, making sure that there's a clear flow of information and transparency as to why the organization is in a value-based contract, what the implications of the contract are, and what needs to be done to be successful.
Great. Next question is how will we know when our organization is ready to move into downside risk?
Yeah, that's a tough one. Thanks for a tough question there. What we try to do is to assess, through what we've seen successful. So those 3 points where we see our high performing client partners working, we try to share that information. We even see it within certain state Medicaids. I'll point out to Idaho. There's been a lot of sharing of information cross payers, cross provider organizations, where in that state there's a tiered payment system. Also in like the long-term service and support in Tennessee with TennCare. We see that the facilities, the nursing facilities, the long-term cares are actually helping each other, to say, well, this is what we do. This is why we're at a tier 1 payment. This is why we're at tier 2 and how we move there. So that sharing of information. So it's not just going to be directed down with technology. It's going to be with organizations helping other organizations for the better of all outcomes.
Yeah, great. Okay. Yeah, very good. And good question. Next question here is this person says, this is great information. Thank you. Would you please confirm the V28 timing of the code implications? In other words, coding now affects payments in the year 2024.
Yes, and that is confirmed. So, and this applies just to the CMS HCC model, and specifically we are looking to the Medicare Advantage organizations. So the HCC program, the risk adjustment program for CMS MAOs, has a large window of time that's associated with it, but those initial payments in 2024 are based on 2023 data, as well as late year 2022 data. So there's a calendar laid out of the dates, but we actually are looking at those initial 2023 dates of service that will impact the payment in 2024. So not a lot that the plans can do about it, because this is really, up to our providers to be capturing these diagnoses appropriately, but this will impact MAO payments beginning in 2024.
And
And there is a calendar that lays out the reporting periods. So you can find that on the CMS website for risk adjustment or HCC payment periods.
And I think that's why CMS, with the final rule, addressed it through a 3-year migration period. I think that was a lot of the feedback they got on the proposed rule.
Yeah, great stuff. Next question here is, have you found that the providers are receptive to Edifecs educational programs?
Want to take that, Mike?
No,
Well, so the thing of it is that Edifecs themselves, we are not an education provider. We are not an education consultant. What we provide is the technology and the data analytics to drive organizational education. So we can give you the evidence to back up where you need to create education or bring in that education consultant, but we ourselves do not take on the education directly.
Well said.
Yeah. Okay, next question, kind of back to the coding. Says, and this is the same individual that had asked the previous question, said also I've heard that some of the codes that no longer affect HCCs are the diabetes ICD-10 codes. Is that accurate?
Well, no, diabetes is still an HCC risk adjustable diagnosis code. The changes that are occurring is that one, the HCCs are being changed. So instead of the beloved 17, 18, 19 HCC for diabetes, I believe we're now going to 35, 34, 35, 36. What is changing fundamentally is the coefficient value. So previously, simple uncomplicated diabetes, HCC 19, had a fairly low coefficient. HCC 18, which is our diabetes with complication, had a higher coefficient. And our highest HCC, HCC 17, had the highest coefficient. In the new model, version 28, all three of the HCCs associated with diabetes will have the same coefficient. I believe it is 0.166. So no longer is there added value or added weight for a patient with complicated diabetes versus a patient with simple uncomplicated diabetes. There was a lot of controversy and a lot of commentary about this proposal. However, CMS has stood firm and said that for the time being, at this point, all three of the HCCs associated with diabetes have the same coefficient value. But diabetes is absolutely still an HCC condition because it is incredibly significant and affects so much of our population.
Indeed, indeed it does. Okay, great answer. Next question is, what technology tools exist to support your strategic approach?
Yeah, I'll start with that because as I mentioned, a lot of the population health management systems out there, the EHR, EMRs, do a lot of great things on the clinical side and the care coordination side and the documentation side. What is needed in a value-based contract is to look at the financial side. So that's what Edifecs provides, not only the financial side, but also the coding excellence. So through both financial and coding excellence, we feel that our solutions augment existing systems that are doing a great job today.
Wonderful. And we have time for one last really quick question. And again, back to the coding. What is the date of the final rule where I can find the details for this?
The final rule was actually supposed to be issued on April 1st, and it came out a couple of days early. So I think the official publication date was March 28th. If you search on Google, I believe if you just use CMS HCC final announcement, it will take you to the website. I'm giving that off the top of my head, so don't hold me to it. But the proposed announcement and the final rule is located in the same place. There is a dedicated spot on the CMS website for the risk adjustment HCC program and the final rule announcements. It's a fairly exhaustive document, so a lot of information in there. When you find it,
Sure.
have fun reading it.
Wonderful. Well, thank you guys so much. Unfortunately, we are out of time, so I wanted to thank again Michael and Betty. This was very informative. And as we close out here, I would like to invite everyone on the presentation today to go visit VBC Exhibit Hall and check out the Edifecs virtual booth that they have here. There's a lot of cool information, a lot of great resources that they have here that you can read and download. Kind of gives you a snapshot of what they're doing in the space, and then you can interact with the team and such there. And then finally, if you would like to reach out to the Edifecs team directly, you can reach out to Abby, and Abby will field your questions, and we'll put you in touch with the right folks, and her information is on the slide here. And then, of course, you can also, if you want to reach out to me as well, I'm happy to facilitate an introduction for you. So thank you all so much again for your time today and for joining us. Thank you again, Michael and Betty. Hope to see you next time on future webinars. Thanks so much.
Thanks so much.
Bye-bye.